Antidepressants are increasingly prescribed for managing various pain conditions in adults worldwide. While traditionally used to treat depression, these medications are now often recommended for chronic pain, fibromyalgia, neuropathic pain, and even postoperative discomfort. Their use has grown steadily, with drugs like amitriptyline and duloxetine seeing rising prescription rates. However, much of this use is off-label, meaning the medications are not officially approved for pain in many cases. This editorial explores the current evidence on how effective and safe antidepressants are for pain management, and highlights the key knowledge gaps that remain in the field. Recent comprehensive reviews, including a 2023 Cochrane review, have shed light on which antidepressants are most effective for pain relief. Duloxetine, a serotonin norepinephrine reuptake inhibitor (SNRI), stands out as the most effective for reducing pain intensity in chronic pain conditions. Milnacipran, another SNRI, also shows promise. However, for other antidepressants such as selective serotonin reuptake inhibitors (SSRIs) and tricyclic antidepressants (TCAs), the evidence is less convincing. SSRIs seem effective only for people with both depression and chronic pain, while TCAs show some benefit for irritable bowel syndrome and neuropathic pain, but the certainty of this evidence is low. Certainty of evidence supporting antidepressant use for pain varies by condition and drug class. For back pain, postoperative pain, fibromyalgia, and neuropathic pain, the evidence for SNRIs like duloxetine is moderate. For other conditions such as knee osteoarthritis or medication-induced pain, the certainty drops to low. Importantly, many studies group different pain types together, making it hard to know if results apply to specific conditions. This lack of precision means that while some antidepressants show effectiveness, the overall confidence in their benefit for most pain conditions remains limited. Even when antidepressants like duloxetine reduce pain, the actual improvement may be small. For example, duloxetine lowered back pain scores by about 5 points out of 100 after 3 months, a change considered minor by many clinical standards. However, some experts argue that these thresholds may not fully capture what matters to patients, such as improved daily function or quality of life. The context in which patients and clinicians decide to use antidepressants for pain is complex, and small improvements might still be meaningful for some individuals. Safety is a major consideration when prescribing antidepressants for pain. Evidence suggests that SNRIs like duloxetine and milnacipran, as well as TCAs such as amitriptyline, can increase the risk of adverse events including dry mouth, constipation, and drowsiness. However, the data on safety is often imprecise due to small sample sizes in clinical trials. For SSRIs, the risk estimates are especially uncertain. Larger studies indicate that antidepressants are generally safe, but more robust research is needed to clarify the risks when these drugs are used specifically for pain management. Significant proportion of trials investigating antidepressants for pain are sponsored by the pharmaceutical industry. In fact, nearly half of all such trials have industry ties, and this number is even higher for studies showing positive results, especially with SNRIs like duloxetine. Industry sponsorship can sometimes lead to inflated effect sizes, raising concerns about the reliability of the findings. Independent, high-quality trials are essential to provide unbiased evidence and guide clinical decisions more effectively. Despite the widespread use of antidepressants like amitriptyline for pain, high-quality evidence supporting their effectiveness is lacking. For example, the evidence for amitriptyline in treating back pain is very uncertain, with studies showing both potential benefits and harms. This uncertainty has led some guidelines to recommend against its use for chronic back pain. Recent trials, such as the Atlantis study on irritable bowel syndrome, have provided better evidence for specific uses, but more large, rigorous trials are needed, especially in older adults and other underrepresented groups. Two major knowledge gaps persist in the research on antidepressants for pain. First, there's an overrepresentation of industry-sponsored trials, which may bias results. Second, there's a lack of high-quality independent studies on commonly used antidepressants, especially in populations like older adults who frequently use these medications for pain. Addressing these gaps will require new large-scale trials that are free from industry influence and focused on real-world patient need. Summary: antidepressants can be effective for certain pain conditions, but the evidence is often uncertain or limited for many drugs and pain types. Safety concerns and research bias further complicate the picture. There is an urgent need for better high-quality trials to fill these knowledge gaps, identify which patients are most likely to benefit, and understand the mechanisms behind antidepressant effects on pain. Only with stronger evidence can clinicians and patients make truly informed decisions about using antidepressants for pain management.